It is 8:21, and joining us now, Dr. Michael Lim, cardiologist with SLU Care and SSM Health SLU Hospital. And I was telling Dr. Lim, this is one of my favorite segments when I listen in.
Thank you.
And you also, I told you, you sound like my neighbor, who is also a physician over for SLU. So you have a voice doppelganger.
All right. We're going to have to get him to work for me.
You have some interesting information today about a potential test, a screening, calcium screenings.
So I think this is the last sort of segment we're doing during Heart Month on this show, and kind of wanted to bookend it. You know, we started the concept of February's Heart Month and try to be aware of your cardiovascular risk or risk of heart attacks, risk of strokes, and increase awareness. It still is the number one killer of folks in this area, and so increasing awareness and trying to tackle these things so they don't happen is very important. The next natural concept when you start thinking about that is kind of falling into what I think is a trap, and that's the testing trap. We can certainly, as physicians and in the medical profession, apply millions of dollars of testing. And if the general concept is, if I do these tests because my quote-unquote doctor wants them, I'm going to have a heart attack that's prevented. That's the guise which a lot of this stuff goes on. There's been a lot of advertisements over the local media about calcium screening, which is a fancy CT scan or CAT scan of your chest. It looks for calcium within the coronary arteries. Loosely, that calcium will predict your potential future risk for a heart attack.
Does the test, is it definitive in distinguishing between calcium and maybe something else that's in the heart? I mean, can it pick up calcium and it knows it's calcium?
Absolutely. Great question. It is definitive. So, X-ray tests are very good at picking up calcium and looking at things like bone, which are made up of calcium. And so it has a very distinguishing image signature. And so you can see calcium, and calcium indicates that you have pretty aggressive and long-standing disease within the arteries to the heart, and so it's not a normal finding ever.
So it sounds like we should all rush out and get calcium screenings.
Right, it does, and so that's a little bit of the let's press pause for a second and kind of think. So there's a lot of different ways we can screen people. And by the book, when we start looking at screening, what we want to do is, first of all, we want to look at what is called the incidence of disease. So how prevalent is it? And if we look at calcium in arteries, in folks we'll just focus on your listeners, everybody over 50 has, unfortunately, a decent chance of having calcium in their arteries. And if you're over 60, you have a better chance. If you're over 70, you have a much better chance. So we're going to find calcium in a lot of people of this age group. So then the next question is, can you do anything about that calcium that's actually going to either prevent a heart attack or stroke or improve that person's life?
That's true. I mean, knowing something is fine, but if it doesn't make any difference, if we can't change an outcome, it's less relevant.
Absolutely. So that's a question that's not necessarily asked before these tests are obtained, and it's a really important question, as you just pointed out. If people are already on cholesterol-lowering therapy, if people already have opportunities to change their diet, if people have an opportunity to actually have a clinical risk assessment done, which would be just come in and see your doctor, and we can run through things like your blood pressure and your cholesterol level and your age and your risk factors in terms of what your family history looks like and what else is going on. We can look at things from a clinical risk standpoint without a test, and already recommend potential lifestyle changes. Obviously, if somebody smokes, that's a lifestyle change that can be recommended and encouraged. If somebody doesn't exercise regularly, that's a lifestyle change that can be recommended and encouraged. Diet is recommended and encouraged, and sometimes medications like lowering cholesterol and these use of these things called statin medications. Sometimes, if somebody's at high enough risk, adding an aspirin a day. And these are things that can be done, and it's not necessarily done because of a test, would be the point. So there's good applications sometimes to testing, but oftentimes we skip the actual conversation.
Getting back to your original point of, well, if we find out there's calcium, is there anything we can do with it? Is there something you can do? You find calcium, can that be reduced as a result? I mean, does that clear out if you do certain things, you exercise or with medicine?
So basically, the unfortunate answer is no.
Just stays there.
So the concept of what we would call coronary artery disease, or the development of plaque and blockages that don't necessarily have to be completely closed blockages, but development of narrowings within the coronary arteries, that's an incurable disease state. That's something that once somebody has, that's something that person has for a long time. Now that disease does not have to affect that person. Right? You can still get enough blood flow around a pipe that's narrowed, as long as that doesn't rupture and have progression to it. So you work on the things that we just talked about. We work on diet, we work on exercise, we work on the application of appropriate medications. If those already can be determined to be put in place without a test, then you can avoid a test. Now, why would we want to avoid a test? Well, there's every CAT scan that we do exposes a patient to radiation, and that's a different risk that we add to a patient's profile. And so, the problem with respect to medicine is that it should be individualized. It should involve conversations. It should involve a doctor-patient relationship, and it should make sense. And in the current day and age where there's so much time pressure, and there's so much economics, and there's so much money involved of, well, my insurance will pay for this or won't pay for this or that kind of stuff, those things I think have been minimized. And so I think, my point this morning is, let's stop minimizing those. Let's start talking to our doctors again. I would enjoy a conversation many times today with the patients I'll see regarding just what we talked about. And there is not a time limit that I have when I see my patients. It's a conversation so that makes sense to them, and what we want to do and what our opportunities to decrease their chances of having heart attacks and increase their chance of doing well. That's a great conversation.
My mother has worked for a primary care physician all her life, and I've had the same doctor, and when I have those conversations just with them as friends, what they tell me is, we are under such pressure to get people in and out. We are given a time. This is the amount of time that you were told to spend. And if you are in a practice that is maybe overseen by a bigger entity, you're telling you have to schedule X number of people. And if they give you 15 patients in 1 hour, you know how much time you have. That's, I think, what you're talking about, Doctor. If all you're doing is going in and checking the boxes, you're not having that important conversation.
Well, true. So there's pressures on what we do. There's pressures on what you do this morning. You have to fit in your segments. You have to fit them in the slots. Sometimes they run a little bit longer because the conversation might continue, but you also have to fit in commercials and other things. And so the art to it is to try to use appropriate flexibility, and sometimes there's harder cutoffs, but there's a lot of individualism to what you do this morning, which I would say is not that much different from what I'll go downstairs and do starting in a few minutes. So yes, there's patients scheduled in time slots, but those patients are people that have very significant and important issues. That's my personal concept of being a physician, is that has to be at the highest level of importance.
And that's why I've been with the same doctor for 30 years, because that's what I find with my doctor.
And that's the perfect concept. Whereas if you feel like you have a doctor that listens to you, that has your best interest at heart, and is guiding you the right way, where you have confidence in your physician, then that's perfect. That's exactly the way it's supposed to be, and that's the bar that any person should have of their physician.
All right. Thank you so much. Again, my favorite segment, Dr. Lim, Dr. Michael Lim, cardiologist with SLU Care and SSM Health, SLU Hospital. Great to have you on, and I'm sure the listeners look forward to hearing from you next week when McGraw is back in the office.
Yeah, so thanks. I hope everybody has a great relationship with their physician, and go in and check it out.